Thank you for coming out this evening. As was mentioned, I'm a hematologist oncologist. I have a particular interest in breast cancer, and that's the main focus of my practice for the last few years at Winthrop. So without further ado, I must preface this by saying that a lot of these excellent looking slides were prepared by one of my students, Michelle, who I think is just walking in. She is a student at Stony Brook, who's an aspiring doctor. And thank you, Michelle, for the slides. That's Michelle's dad, so okay. So, first of all, Chemo Brain, as it's colloquially known, was a term that probably gained prevalence because patients designed that term, they coined that term. Till the 1980s, people didn't recognize that it existed. A lot of the research about this very important question developed since in the 1990s. So let's talk a little bit about the definition, what are the symptoms, who's at risk, and then let's look at the research that's been done on this very important subject, because it's a nebulous area. It's hard to define, and a lot of times people didn't think it existed. But clearly, as research has shown us, there are some tangible areas, some proof that we can use to tell us that this really does exist. We'll also talk about what could potentially be causing it. And another area of very important research, how can we treat this? So what is Chemo Brain? Just a little cartoon that Michelle found for me. It's pretty accurate, I think. Unfortunately, it is not just a disease of the elderly, though in a lot of ways, age and impairment of memory go hand in hand. And in fact, some of the theories that exist about Chemo Brain suggest that it's just an acceleration of what would naturally happen with aging. Is that somehow chemotherapy, cancer, whatever treatments we use, the whole situation of having cancer somehow accelerates the aging process. And therein lies the link, except that it happens to not so old people. It can also happen in elderly people, but it can happen to young people as well. So in a nutshell, the definition is it's a term to describe thinking and memory problems that can occur while people are on treatment, and unfortunately, in a lot of times, it is after you finish the cancer treatment. It can last for many, many years. Some people see it resolve, and some people don't. We'll talk about what predisposes patients to resolution and not. And then the hallmark is an overall weakening of cognitive functioning. Essentially, it's language ability, memory, concentration, attention. Other terms that one has heard: chemo fog, chemotherapy-related cognitive impairment or cognitive dysfunction. I'm going to tell you that the word chemotherapy, and we abbreviate this by calling this CRCI. The first letter there, C, stands for chemotherapy, but in a lot of ways it is actually cancer-related. So as I'll show you later, it's not just chemotherapy that can cause this phenomenon. It's the situation itself. So cancer in itself can cause this, and so I think one of the moves in the oncology community is to redefine chemo brain as cancer brain. Who is at risk? Studies have shown us that anywhere from 17 to 75% of women experience cognitive deficits from 6 months to 20 years after exposure to chemotherapy. Why is there such a wide variation? Part of the reason is because research is hard in this area. A lot of it relies on patients' abilities to fill out forms, questionnaires. Different life experiences are different. Recently, there's been more imaging, more MRIs and studies that can objectively tell you what the changes are. But a lot of the research that was done in the early 90s really relied on patients filling out questionnaires. And so as you can imagine, there was a wide variability. Some of it was reproducible, some of it was not. It doesn't change the fact that this is a real problem. It does exist, and the numbers may be somewhere in between 17 and 75%. As our treatments get better, we evolve and use less chemotherapy, they may change. It is also a known fact that patients who are high-functioning individuals become more likely to notice very subtle changes. So when you fill out a questionnaire, somebody who's a school teacher, for example, might have a different level of functioning from somebody who's a homemaker. And what is important to that person might be different, so the memory skills might be different. And so therein lies the wide variation in defining what really is the cognitive impairment. As I mentioned earlier, cancer and aging are linked, and the molecular mechanisms might be common. One of them, in fact, is a process, when we know this occurs as people age, their chromosomes get shorter. And chemotherapy can also cause the same damage to DNA. So can other therapies like radiation therapy. So there is definitely research that shows that aging is linked very closely, and women, as they get older, tend to be more prone to the effects of cancer and cancer-related treatments. So symptoms, I think everybody is familiar, and some of you might have your own. I encourage you to share them beyond what I'm going to show just now. Forgetting things that one would usually have no trouble recalling. Maybe an insult that somebody, I don't know, well, somebody insulted you at a party and you remember that usually, but now you don't. That's a good thing. Forgetting more pleasant things could be a problem. Trouble concentrating, we hear this a lot. People who are working in offices, secretaries, they can't focus on what they're doing. They space out. They sometimes don't even know where they are, and that's where the word fog comes from. It's almost like they're working in a fog. Trouble remembering details, a very big one. Names, dates, anniversaries. You can't multitask. Can't do two things at once. People who had no problem talking on the phone and fixing kids' dinner now have trouble doing that. Can't fold the laundry and speak on the phone. So there's an issue, you lose track of the conversation. You take longer to finish things because you feel that you're moving from task to task and you're not sure what to complete first. So that's a very common phenomenon. Trouble remembering common words. We hear this more and more. It's on the tip of your tongue, you just can't say it. And fatigue. A big part of this phenomenon is fatigue. I'm going to spend a little more time on cancer-related fatigue, which is an entity in itself and can be measured, but it's also part of what defines cancer cognitive impairment. So cancer-related fatigue is the most common side effect of cancer and its treatment. Once again, it's not just the treatment, it's the actual process of going through a diagnosis of cancer and anticipating the therapies. It occurs in close to 96%, 60 to 96% of patients during treatment. It can persist for months to years. And 30% of breast cancer survivors report fatigue even 5 years after diagnosis, and some can report it more than 10 years, up to 10 years after diagnosis. And if you ask some people around the room, it's probably even longer. There's always a sense of cancer fatigue. It's different from normal fatigue. Normal fatigue is you're up all night with the kids, or a late night movie, you're tired, you're overexerting yourself, you're handling too many things at one time. This is different. It feels like you're fatigued without actually doing very much, but your mind is racing all the time. It's very pervasive. It can be very debilitating. It can certainly be longer lasting. And as it says there, it can involve a lot of emotional components, and it does not seem to be relieved no matter how much you sleep, how many medications that help you to sleep, or even a nap in the middle of the day. It does not seem to relieve it. So that's sort of the phenomenon of cancer-related fatigue, which is very different from regular fatigue. Here's just an example. It could be anybody. A professional woman, she could be a nurse, a school teacher, a lawyer, diagnosed with breast cancer. Now we start chemotherapy. There's no more menses. So the hot flashes, there's a lot of other side effects that go with that. Now we start tamoxifen. She has 2 school children, aged children. She works full-time. It's now 6 months after chemotherapy. She's been so busy with the treatments and making sure the kids' schedules are not interrupted, she forgets about her life for a while. And now, 6 months after chemotherapy, there's a huge vacuum. We're done with treatment, you're on a pill, now what do? Now she gets back to life, and she finds that she can't multitask. It becomes more evident once you're actually done treatment. Things may have been settled during treatment, but you're actively involved. But once all that treatment's over, you're no longer going to the infusion center, the doctor, for those regular visits. Now you realize that you can't do the things that you did. And post-chemotherapy, the follow-up with physicians, this is the most common complaint. I can't remember things. I don't know what the kids are doing at school. I just can't do the math that they were doing before. And now there's anxiety. There's anxiety, not just personal anxiety about the cancer recurring, but also what's going to happen to my family if I can't be with my kids and I can't teach the kids. You're sleeping poorly, there's hot flashes, there's night sweats. What's happening? Well, it is cancer-related cognitive impairment. that is exactly the phenomenon that we see. It could be a different experience for different people, but this is classically somebody that could be anybody in the audience. So what does research tell us about people like this? Well, first of all, there was a small study that looked at women who had breast cancer surgery only. They were given a diagnosis, they had the surgery, and when they were tested, 1 in 4 already had problems with word skills, and 1 in 7 had memory issues. So this tells us that just the diagnosis alone created this problem. And although surgery, maybe the anesthesia or other drugs could have contributed, a lot of these women also reported that they had a higher stress level even before they started the actual chemotherapies or the hormonal therapies for this condition. So it's a natural phenomenon. Stress levels do go up when you have a diagnosis, but different people adapt to it differently. And so what we do know is that chemotherapy is not the only reason for this impairment. This was a very important study that actually showed that it was a study at UCLA that became one of the leading studies of the time. It looked at 189 women with early stage breast cancer. The mean age was about 52 on this study. And they looked at patients 1 month after just the surgery, and before they had other treatments, before they had hormonal therapy. As you can see, some of them had lumpectomies, some of them got chemotherapy, 70% had plans to take the treatment, the hormonal therapy, and about 75% had radiation therapy. They matched those women with women who didn't have breast cancer. Both groups of women filled out a questionnaire that looked at their thinking skills and took neuropsychological tests, looking at various tasks, visual, memory tasks, executive memory, different kinds of tasks that are standardized tests, and the researchers administered them. Women with breast cancer who were just diagnosed had many more severe complaints about memory and problem solving compared to the control group. In fact, 23.3% of the women had memory issues. 19% of them had problem solving and reasoning complaints. And women who had both memory and problem solving complaints were more likely to have both chemo and radiation. So it seems that every therapy adds on to the likelihood of having one of these issues, but the problem can start right after diagnosis. And women who had the lower test scores had very severe complaints. So the lower the scores, the higher the incidence of these problems with memory and thinking. They had both, as I said, chemotherapy and radiation. And interestingly, they also had symptoms that were consistent with depression. So it seemed that even though there was no clinical diagnosis of depression, there were certainly symptoms that suggested that diagnosis, and treatment may have been appropriate for women who had that kind of picture. So these were neuropsychological tests that women filled out. What about the rheological evidence? As you can see, the ones on the where it says chemotherapy left for me, and no chemotherapy on the right for me. The untreated patients had more activation in something called the parietal cortex. Unfortunately, I can't point here, so I'm going to. Right here. So that bright yellow spot there is, the patients were asked to recall short-term memory, and that's the area that controls it. And patients who had never received chemotherapy had a nice bright spot there. But the people who had chemotherapy in this study in 2007 didn't have a bright spot there. So clearly there was a problem with short-term recall in patients who had chemotherapy, and the imaging proved that. Similarly, this is some other evidence from a twin study. The patient on top is a patient who has breast cancer, and the one below is her identical twin without breast cancer. And as you can see, there are different areas that light up in both the brains. They were asked to do simple tasks, visual, memory, again, judgment, and much less brain power seemed to be used in twin B, the lady without the breast cancer at the bottom. She didn't really require to use as much of her brain power as the lady in panel A, who was treated with, or who had the diagnosis of breast cancer, for simple tasks. So even simple tasks require you to use a lot more of your brain power, and that's what the MRI showed. And that's probably why it took longer, or it required more coordination for the patient with the breast cancer diagnosis. Otherwise, they were identical. The genes were identical. What we do know now, so that this problem is multifactorial. It's not one thing. Chemotherapy can certainly do it, hormones can do it, immune therapies can do it, radiation can certainly do it, and so can surgery. And sometimes, depending on where a patient's psychological level is, depression, stress, anxiety does not have to be a diagnosis of depression. It could be just some symptoms that can predispose. And it's, as I said, it's more than just chemotherapy. Here's a slide that shows 3 different groups. The very light green is patients who had the performance scores but had no treatment at all. The one with the blue, dark blue, is chemo only, and the really dark green is chemo and tamoxifen. This was a study in 2004, and they looked at patients in different areas, and the ones who had combinations of therapy actually had a poorer performance, the one below the line, compared to the ones without therapy. So there's clear evidence that this exists. Some of the things can be fixed. So what can we doctors do to fix some of these things? Chemotherapy cancer can cause anemia. Being anemic can make you tired, can make it hard to focus. We can fix that. Fatigue is a much harder thing to fix. There are ways and means of fixing it beyond allopathic medication, and certainly Dr. Genovese will help with some of them too, and I'll talk about them at the end. We can treat infections. You can get very sick from having a urinary tract infection while you're getting chemotherapy. It can make it harder for you to recover from a bout of treatment. We can fix those. Menopause, harder to fix, especially since we're trying to block the hormones in the majority of patients with estrogen-positive breast cancer. But there are certainly other ways that we can treat menopausal symptoms. Hot flashes, the fatigue, certainly ways we can do that. And one area that we rarely mention is patients who feel that their libido, their sexual habits are changed because of treatment. They've lost interest in themselves and in sex with their partners. That can play a very important role too in the way women's self-image and self-esteem. And those are some things that we can fix, or at least try to fix. Nutritional deficiencies. A lot of women lack lack vitamins. I'm not saying that we have to have super high levels of vitamins, but it's a simple matter to check the vitamin B12 levels or the vitamin D levels. If you're anemic, those are things that we check anyway. Your iron levels, and make sure that they're okay. The majority of times, women who go back to eating normal, healthy diets don't always have nutritional deficiencies, but this is one area we always check for. It's also pertinent for women who have neuropathies from chemotherapy. We always want to make sure that it's not exacerbated by a B12 deficiency, for example. Insomnia, another really big problem. Again, sleep aids, we can try those. We can try some non-invasive or non-medication methods to improve sleep. But there are some factors that can't be fixed, and research is very active in those areas. The 2 that I've mentioned at the bottom, there is a variant of a gene, it's called the APOE gene, and this E4 variant is a variant that's seen in Alzheimer's disease. And this is something that researchers are looking at in women who are being treated for breast cancer. And there are studies that show that in women who have therapies for breast cancer, there seems to be a change in the E4 gene, or there's a mutation in the E4 gene, even before they start treatment. So what that tells us is there may be some genetic factors that predispose some patients to cognitive impairment more than the average person. So we can't really change the genes, they exist. Hopefully with time we'll be able to reverse some of this or figure out a way to fix this before it happens, but there definitely exist pre-existing genetic factors. And then another important area of research is inflammation. But inflammation is a normal phenomenon when you're injured, when you're infected, when you have surgery. Every time you're injured, there's a release of pro-inflammatory cytokines, which are essentially proteins, substances that circulate in the blood and can act on different organs in the body. One of them is this TNF. There's definitely some interest in this because there are drugs that can block the TNF and have been looked at in areas like rheumatoid arthritis, for example. But TNF levels seem to be very elevated in patients who complete chemotherapy. And so research is looking to see whether you could explain impairment, cognitive impairment in the brain with an elevated TNF level, and maybe for the future, blocking that TNF level might help reduce some of the incidence of the cognitive impairment. So these are 2 active areas of research. It's not something that's in the clinic just yet, but certainly something to look forward to. Lastly, I'd like to talk about prevention and treatment. First of all, it really exists. Reassurance at all times. I can tell you that doctors believe it exists. It's very real. They are not necessarily caused by chemotherapy, so they should not be the reason why patients refuse to take chemotherapy, though that can be a deal breaker sometimes, because it's sometimes for some patients, they would rather deal with the cancer than memory loss. But as I've shown you, it's not just the chemotherapy, so one has to really decide what it's worth. What we can do as doctors is use chemotherapy judiciously. Try to avoid it in early stage cancers. We certainly have a lot of ways of figuring out who needs chemotherapy and who doesn't. Certain histologies, we still have to use chemotherapy. The HER2 positive subtype, for example, women who have triple negative breast cancers. We're still using chemotherapy because the benefits at this time outweigh the risks, and so we still use that. But for patients who have small estrogen positive cancers, we've already moved away and we've started to tailor therapy to who really deserves that chemotherapy or needs that chemotherapy. We certainly would like to treat anxiety, depression, any kind of symptom if it exists before you actually start chemotherapy would be a good time to fix it. Ideally, it would be better to start fixing that when you first see the patient before surgery, because when you first get the diagnosis, it would be good to know what a baseline level is. And certainly, if there's no improvement a year after you've finished all your treatments, obtain what we call a neuropsychological consultation. As Dr. Jalmizi and I were talking, they're harder to come by. There's certainly resources that I'll show you at the end one could use to get these consultations. Neuropsychologists require extensive training. They're the psychologists who do the MRIs that actually look for those changes. But in my practice at least, if I find that people are having real issues, I would recommend a neurology evaluation, make sure there's nothing else that could be fixed, make sure there's no nutritional deficiencies, and yes, a psychological evaluation as well, because I think they go hand in hand. Track it. Track the memory problems. This is a feeling of being in control. You know, I know even just from being a mother and a doctor, there's a million things on my mind, and I have not even had the diagnosis of breast cancer. I can't remember day to day for what I have to do next. Thankfully, we have PDAs and my little Palm Pilot here. So I keep a diary of when you notice. Keep a diary of when you notice problems. I keep a diary of things that I have to do, mostly online. But make a note of what are the events going on around that. What makes you forget things? What are the situations that make you anxious? Make a diary of when you need to take medication. Don't rely just on your memory, and it's okay to do that because this is a real problem. Having a way to track when you're forgetting things puts you back in control. You'll also need to know when you need to avoid certain kinds of appointments or conversations. Especially when you're already doing something else. You're at a ball game. You do not want to have an important conversation with your doctor at that time, or your lawyer for that matter. You really don't. That applies across the board actually. And when you talk to your doctor, bring a list of things that you want to talk about. Writing those questions down helps not just you, it helps the doctor. It's a permanent record, and I have a practice of actually putting those questions as part of the record, because I note my answers to every single question, and it works as a permanent record. So, speaking of recording everything, record everything. Keep a track of appointments, to-do lists, movies you want to see, a bucket list if you have, track it. And record everything. Learn to adapt. This is probably easier said than done, but follow your regular routine. Keep a certain place where you want objects that are easily lost, for example, your keys. I know somebody who keeps the keys in her underwear drawer. She knows she's going to visit that drawer at least once a day, so it's there. Whatever works for you. So try to keep the same daily schedule. Don't try to multitask. Some people pride themselves on being able to multitask, and then when they can't, it's extremely hurtful, it's very distressing. Just don't try. My usual advice is don't set the bar too high, because when you fail, it's that much harder to accept that you have. But remember that it's not a failure. This is something that we've been doing to you, that cancer did to you. So don't try to make it worse by trying to achieve that high bar. Avoid distractions, definitely, and most importantly, exercises to train your brain. Word puzzles, Sudoku, crosswords if you like, learn a new language, make that part of something you want to do, volunteer at a local program, a new exercise, and if you've never done yoga before, try yoga, something different. Learning a new skill very often allows the brain to focus on that, but don't try to do two things at one time. Pick one and try to master that. Focus on the mind and body, in keeping with that theme. Get rest and sleep, exercise, and eat your veggies is what this says, and this is from the American Cancer Society. But my advice is to eat a regular, normal, healthy diet. no fat diets. We know that there are lots of medications out there that can help with brain power, but nothing can beat good, healthy, non-processed food. So unprocessed food is the key here. Doesn't mean you don't have to go on a fat diet. And most importantly, try not to focus on how these things bother you. You're not stupid, you're not crazy. You just have a side effect that you have to manage. It's not visible. Hair loss is visible. Skin changes are visible. This is not visible, it's subtle. So accepting it is probably the best thing you can do for yourself. And sometimes you need to laugh about it. That may be a coping mechanism. You don't know why you went to the fridge, you opened it up and you have no idea why you're there. You walked all the way down thinking you were going to get laundry, but now you don't know why you're there. So those are things that could happen to anybody, and maybe more so with patients who get chemotherapy or cancer treatment. So this might be a good coping skill. Sometimes it's easier to laugh with a group. It may be easier to laugh with a group of friends or a glass of wine. We didn't talk about alcohol yet, but we'll get to that. You're not alone. Ask for help when you need it, because friends and loved ones can help. They may notice things that you haven't. They may be able to tell your doctor, this is how I perceive this patient, or this is how I perceive my wife, my friend, my coworker, this is how I see them. Even though, and you might be surprised, they may not have noticed things that you did. You might have thought you were slipping, but maybe they didn't notice that. If you can't have a friend, take a tape recorder. I have patients who record every conversation with me, and most of it is good stuff, and they play it back. Playing it back jogs your memory, and again gives you that feeling of being in control. And as always, bring a list of everything you're taking. Don't assume that you'll remember, just bring it in. There are some allopathic medications that have been tried. As you can see, some of them are medications that are used for other conditions which have common etiologies, like attention deficit disorder, Alzheimer's disease, sleep disorders. I can tell you that we're not in the practice of recommending them routinely unless we have a proper neuropsychological evaluation, because these medications have side effects too. And so we would rather not have to just over-medicate you for something that you can adapt to. But there are definitely instances where these could be used, when the fatigue or the cognitive impairment is impairing life in general. This is another very important piece, I think even more important than the other allopathic medications, mindfulness-based stress reduction. I know Dr. Genovese is going to talk to us a little bit about that. Things that allow you to focus on your body, how it's feeling, the strength in your muscles, allows you to move gracefully, simple things that help you feel accomplished. So I think there's a big role for non-allopathic, non-medication therapies, and these are just small examples. There are many other fields of alternative medicine that could certainly be used there. So in conclusion, first of all, I think we should rename Chemo Brain. It's actually cancer and cancer therapy related cognitive dysfunction. It's probably going to be still called Chemo Brain for generations to come, but in our community at least, this is what the push is, to replace the C in chemotherapy with cancer. We know that it's multifactorial. We know that the real impact really depends on patients' pre-existing condition. So trying to identify it early is actually the right answer, right when you're diagnosed. We also know that with adequate support and a good survivorship program, we can actually make an impact, not just from preventing the cancer from returning, but also for life in general. So who are your persons of interest on your list? The oncologist, an oncology social worker, there's very good resources here. If we can, a good neuropsychologist, which should be a consideration for any good survivorship program. I have a list of some resources here. I unfortunately did not put the main one in this area, which is Adelphi. And I think we have some handouts at the end of this meeting, which will tell you exactly who you can contact to get more information, and also to arrange for a neuropsychological consultation. But as always, talk to your doctor. I don't think there's any one of us now who does not recognize this phenomenon and sympathizes. And we don't have all the answers, so I have patients bringing me stuff and I have to look it up. And I'm very happy to do that. The one area that I haven't emphasized here, before I forget, Michelle, thank you very much for your help. The area I didn't emphasize here was herbals. I'm not qualified, a qualified herbalist, and while I absolutely endorse and support some of the medications that patients use, I'm also cautious about what's used during chemotherapy and after. So my usual strategy is to tell patients to bring it in to me, and I will do my research and tell you whether it's appropriate to take for your particular situation. But there are qualified herbal experts. There's a whole field of medicine that evolves around non-allopathic treatments, and I think they should be complementary as they were intended to be. With that, I will stop and have Dr. Genovese take over. We'll reserve questions for later. Thank you for your attention.
Can you keep it down so it's less ceiling? Because I see the lights reflecting in it.
It's hard to hold this still.
Yeah, I know. No, it's not that it's moving.
I don't
Rest it on your arm.
My problem is it's going to stop at the end.
Okay.
I know.
So stop.
Well, I'll let it go as long as it can.
Okay.
Hello.